Here is a detailed comparison between degenerative disc disease, DDD, and ankylosing spondylitis, AS, across 15 key differences. 1. Etiology, cause. Degenerative disc disease, DDD, caused by age-related wear and tear of intervertebral discs. The intervertebral discs lose hydration and elasticity, leading to disc collapse, microtears, and inflammation. Contributing factors include aging, repetitive spinal stress, trauma, obesity, and genetics. Ankylosing spondylitis, a chronic autoimmune inflammatory disease that primarily affects the axial skeleton. The immune system attacks joints, especially at ligament attachment points, entheses, causing chronic inflammation, genetically linked, especially with HLA-B27 antigen. 2. Typical age of onset, DDD, common in middle-aged and older adults, usually after 40 years. Risk increases with age. AS typically starts in late adolescence or early adulthood, 15 to 35 years, rarely begins after 45 years. 3. Genetic association, weak or no specific genetic markers. Some familial tendency due to biomechanical and structural disc traits. AS, strong genetic link with HLA-B27. Around 85 to 95% of AS patients test positive for this gene. 4. Pathophysiology, DDD, discs lose proteoglycans and water. Disc height reduces, annular tears, instability, and osteophyte formation. Leads to mechanical back pain, nerve compression, radiculopathy, or spinal stenosis. AS, chronic inflammation of entheses, ligament, and tendon attachments. Leads to new bone formation, syndesmophytes, spinal fusion, and decreased mobility. Results in a bamboo spine appearance. 5. Pain characteristics. DDD, mechanical back pain, worsens with activity, bending, lifting, and improves with rest. Pain may be localized or radiate if nerves are involved. AS, inflammatory back pain, worse at night or early morning, improves with exercise. Pain is dull, deep, often in the buttocks or lower back. 6. Stiffness, DDD. Stiffness is mild and short-lived, mainly after long periods of inactivity, relieved quickly with movement. AS, stiffness lasts 30 minutes, particularly in the morning, improves with physical activity, worsens with rest. 7. Laboratory findings. DD usually normal ESR and CRP, no specific markers. AS, elevated ESR and CRP in active disease. Positive HLA-B27 in most cases. 8. Radiographic features. DDD shows disc space narrowing, osteophytes, end plate sclerosis, and facet joint degeneration, common at lumbar levels, e.g. L4, L5, L5S1. AS, early bilateral sacroiliatis, late syndesmophyte formation, bamboo spine, fused vertebrae, squaring of vertebral bodies. Spinal involvement, DDD, affects specific intervertebral discs, often lumbar spine. Can affect cervical and thoracic spine too. Begins in sacroiliac joints, progresses to lumbar, thoracic, and cervical spine. Axial skeleton is primarily involved. 10. Extra-articular manifestations. DDD, rare, no systemic involvement. AS, common, includes uveitis, eye inflammation, aortitis, pulmonary fibrosis, psoriasis, inflammatory bowel disease. Physical examination findings. DDD, localized tenderness over affected disc. May have positive straight leg raise test and nerve compression, normal spinal range of motion unless severe. AS, reduced spinal mobility, Schober's test, chest expansion, 2.5 centimeter, postural changes, kyphosis, tenderness over SI joints. 12. Disease progression. DDD progresses slowly, may stabilize. Symptoms can fluctuate, episodic flares, does not lead to spinal fusion. AS, progressive ankylosis, fusion of spine, can cause rigid spine and deformity, may lead to functional disability if untreated. 13. Management approach. DDD, conservative treatment, physical therapy, weight loss, NSAIDs, steroid injections or surgery, discectomy fusion for severe cases. AS, NSAIDs are first line. If inadequate, biologics, TNFI inhibitors, IL-17 inhibitors. Physiotherapy to maintain posture and flexibility. 14. Surgical indications, DDD, indicated in severe cases with neurological symptoms, instability, or failed conservative therapy. Procedures, laminectomy, spinal fusion, discectomy. AS, surgery is rare, may be required for spinal fractures, severe kyphosis, or hip replacement if affected. 15. Prognosis. DDD, often manageable with conservative treatment. Variable prognosis. Some have chronic pain, others adapt well. AS, lifelong progressive disease. Early diagnosis and biologic therapy can slow progression and maintain function, some risk of disability if untreated. Summary table feature degenerative disc disease, DDD, ankylosing spondylitis, AS, early diagnosis and biologics and maintain if untreated. Cause, mechanical degeneration, autoimmune inflammation, age of onset, 40 years, 15 to 35 years, genetic link, no strong link, HLA-B7, pathophysiology, disc wear and collapse, enthesitis and bone formation, pain type, mechanical activity induced, inflammatory, improves with activity, morning stiffness, 15 minutes, 30 minutes, ESR-CRP normal, elevated, radiology, disc narrowing, osteophytes, bamboo spine, sacroiliatis, spine involvement, any level, mostly lumbar, axial skeleton, SI joints, extra-articular signs, absent eye, heart, lung, gut involvement. Exam findings, local tenderness, flexion, chest expansion, disease course variable, non-progressive, progressive ankylosis, treatment, conservative surgical if needed, NSAIDs, biologics, exercise. Surgery common if severe, rare, prognosis usually good, lifelong, controlled with therapy. Thank you. Have a nice day.